Welcome everyone. The special issue is a collection of 12 studies on various aspects of health system strengthening. Today's panel discussion focuses on 3 of the papers in the special issue. Since the emphasis of today's agenda is on primary care, the 3 papers cover key aspects of primary care: financing, service delivery, and human resources. Our first panelist is Professor Indrani Gupta, Head of the Health Policy Research Unit at the Institute of Economic Growth, New Delhi. Professor Gupta is an economist, and her areas of interest cover a wide range of topics in the area of health economics and health policy. Her paper is titled Costing of Health and Wellness Centers, a case study of Gujarat. This paper covers the financing aspect of primary care and describes a costing exercise undertaken in the state of Gujarat to estimate the cost of converting existing primary care facilities to health and wellness centers. Our second panelist is Dr. Dorothy Lal, faculty member at Christian Medical College, Vellore. Her paper is titled Lessons for the Design of Comprehensive Primary Healthcare in India, a Qualitative Study. The study focuses on aspects of service delivery and documents lessons from successful CPHC initiatives in rural and urban India using a qualitative case study approach. Our third panelist is Professor Usha Manjunath, Director at the Institute of Health Management Research, Bangalore. Her paper is titled Assessment of the Workload of Ashas, a multi-stakeholder perspective study for task sharing and task shifting. This paper looks at the human resource aspect of primary care. The study involves an assessment of the workload on Ashas and the potential for structured task sharing and task shifting among other healthcare workers. The session will be moderated by Professor V.R. Muralidharan, Professor at IIT Madras and Honorary Director at India Health Systems Collaborative. Professor Muralidharan's research interests are health economics, history of healthcare in India, and technology and health policy. The panel discussion will be an hour long. Each of the panelists will have 10 minutes for their presentations, followed by 5 minutes for audience questions. After the 3 presentations, there will be a moderated Q&A and the floor will be open to audience questions. I request everyone to please make a note of their questions and ask them at the end of the presentation. We will also be taking questions from the participants on Zoom, so please use the chat box to ask your questions. A team member will collate the online questions, and if there are any questions remaining, they will be answered later by email. Over to you, Dr. Muralidharan.
Good morning. Welcome to this session. This session, which follows what we heard in the first session on the importance of research in promoting and strengthening health system. And we also heard particularly the role of IHSC in promoting such research towards strengthening health systems. What we are going to hear in this session is as illustration of IHSC's efforts in promoting research towards strengthening health systems, 3 case studies. These 3 case studies or studies are from the 11 studies that are published in the special issue that was just released of Journal of Health Management. Before I invite the 3 studies, 3 presenters, we also heard in particular the efforts made by NHSRC's efforts to promote research in strengthening health systems. May I also take this opportunities to say that there are also other initiatives in the country in this direction. For example, the last 2 years, Government of Tamil Nadu Health System Program initiated what is called the OR program, Operational Research Program, which we happen to implement. Already about 15 studies have been initiated. So maybe there will be another occasion where we'll come together to listen to such studies as well. Now with this preliminary remark, may I request the first presenter, I think Indrani Gupta, to make a presentation. So she will take about 10 minutes. Then we'll have one or two questions you may address from the audience here. Then, after all the 3 studies are presented, we will have about 10-15 minutes to ask more questions, both from those who are here as well as those who are online. Indrani, please.
Thank you, Murali. Have you loaded my presentation? It's there? All right, thank you. Fine. Let me just check. So thank you very much. I'm really pleased to be here. I know that this is supposed to be a presentation of the work we did, but I think it's more first time we have come together, we have seen this process of creating this organization, and it's such a pleasure to actually see this happen. So I want to congratulate the team, everybody, Professor Muralidharan, Professor Venkatraman, Tushar, everyone else for creating this, because when it started, we were not very sure how it's going to be actually progressing. So now that we've seen this happen, and NHSRC, Dr. Kotwal is here, I think the spirit of this platform is collaboration. And let's just see more such collaborations happen. Our work, which was one of the first that was funded, was on costing of health and wellness centers, the whole idea being that primary care is so very important, and we don't have enough studies in the country on what it costs to actually run primary care platforms and organizations. So the rationale was basically exactly that. I don't know how, it has its life of its own, so just bear with us. We have a lot of studies under Ayushman Bharat happening on PMJ, for instance, but not enough on HWCs. That's what we thought at the time when we began this. So why do we need to do another costing study? The idea is that if you want to sustain an initiative, if you want to sustain a program that you think is very good, you really need to know how much it costs, not only to understand what it would cost the exchequer, but also to see programmatically what are the various shares, who is going to bear those shares, etc. So that was the whole rationale of doing this study. I'll be very, really fast here. We know that the NHP 2017 recommended it, and about 1.5 lakh HWCs were to be transformed from existing sub-centers and PHCs. And they were supposed to be delivering a broad range of services, because the whole idea was to shift the burden from secondary and tertiary care to lower tiers of facilities, so that people didn't have to bypass the lower tiers. So the kind of services that were envisaged, and this is very important, because did it really actually happen that way? That is a very important question. So a whole range of services have been envisaged under the HWC initiative, including NCD, which is a big thing, ENT, and all kinds of other things. So moving beyond just maternal and child health. Why did we choose Gujarat? Of course, it was our partners that we found, IIPH Gandhinagar, Mayur Trivedi, who is sitting right here, and his team was helping us, but that was not the only reason. Gujarat has been a front runner in the response to GOI's announcement to create HWCs, and the outcomes in Gujarat have been better than average. I mean, actually, we have some, it's not excellent, but at least it's in the middle of the continuum. We also needed more HWCs that had completely transitioned to do the costing study, and Gujarat had that. And Gandhinagar was selected, was offering a 6-month certificate course in community health, so that also helped in briefing up the HWC initiative in that state. So the objectives were many. You already have it published, so you can read, those of you who are interested. I'm just going to touch upon the brief findings. Of course, there was literature review. We analyzed the health and wellness centers well. There was a lot of field study undertaken. But let's just see what the ultimate objective was. We wanted to see whether the pre-conversion and the post-conversion, how the costs differed, and whether it was a sustainable initiative. So the main emphasis was to find the incremental unit costs difference between the pre and post-conversion. The site selection, we selected 8 HWCs were selected, 1 from each kind from 2 districts, Rajkot and Gandhinagar. The consultation happened with the state government, so it was all very participatory. These are the selected sites. You can find the details in the paper, but we had Gandhinagar and Rajkot, and the different dates of conversion need to be noted because that's how we had to collect 1 year of data for each of them. So the dates were all different, and the catchment population that these facilities were serving were also very different. Methodology. Now, in economics, typically we take into account all relevant costs, right? We take into account irrespective of who's bearing the cost, we have to take costing done from all stakeholders' perspective. But interestingly, and for convenience, it was very convenient for us that we were taking a programmatic view, the decision makers' view. So, since we were looking at budgets. We did collect data from the bottom of the tier. So we went to the fields and collected all kinds of data. So we had to collect retrospective data. Now, you include costs of goods and services whose price do not reflect the market price. So you need to use shadow pricing. You include values of gifts and donations, and you have to use a discount rate for annualizing the capital cost. And none of these were actually very relevant for us because there was very little capital expenditure undertaken, so we didn't have to do that, and gifts and donations also didn't really happen in the HWC initiative. The one important thing that is very important in costing that we have done in the past as well is who bears the cost and from which department the costs are going to come, and what are the so 2 departments may be sharing the same services, so you need to allocate the cost accordingly. So those had to be done. So for instance, costs that are incurred from the TB program or malaria program need to be added to the current costing so that you don't underestimate anything. We compared the pre and post conversion, and we did the collection for 3 years, and we did the annual costing. Now, the buckets in which we were collecting the data was human resources, drugs, vaccines, infrastructure, training, outreach, and miscellaneous. Won't get into details, but these are very typical of the kind of cost centers that you see in any costing study. Now, we did spend a lot of time trying to wonder what should be a denominator. I mean, total cost per what? And we had a lot of interesting discussions within the group, and we finally decided that the only thing that we can use at this point is OPD visits, that is footfalls, and that's exactly what we did. So the incremental unit cost of conversion was essentially total cost post-conversion divided by OPD footfalls post-conversion minus total cost pre and divided by OPD visits pre. So that is essentially a very simple concept to find out the incremental costs. If you look at the total OPD visits by centers, these are the various sites that we selected. You didn't find, it's not stark. The increase in footfalls were not that much. Only the sub-centers saw a substantial increase in footfalls, which is essentially what we would expect to see. That's what happened here. Then if you look at the increase in total costs, again, the costs did go up. They differed widely for the same type of facility. They increased for all the centers, but the maximum increase happened again in the sub-centers. And they had, this new community medical officer, so that is one of the reasons. And the least increase has been in the PHCs. This is the total cost figure, but let me just come to the main points. The share of the components is very important because ultimately, if you are going to scale up, you need to know how much the center is going to spend, how much the states are going to spend. And as you can see, the states are actually, they have a greater share in the total cost, and that happens in most programs. the sharing is typical of NHM model, but the states do end up spending a little more because they do add on a lot of the components from their own budgets. So the states bear the bulk of the costs. If you look at drugs and vaccines, as expected, drugs comprise the greatest share, and that has gone up a little bit in the the HWC initiative. As expected, there is a drug program. The drugs are now coming in more regularly. So, but otherwise, there's not much of a change. Now, scaling up. Ultimately, what do we see? So there are 4 kinds of conversion, right? Sub-centers, PHC, urban PHC, and corporation PHCs, urban PHCs. The costs, incremental costs, differ a lot across all of these categories. But if you take an average for now, it's about 94 crores. Now, is this high? Is this low? How do we interpret this number? I would say, first of all, if you'll notice that the maximum increase is for the sub-centers and the least increase is for the urban PHCs. Now, if you have a target of 1,000 sub-centers to be converted, for instance, the total cost of running would be considerably lower at 187 crores compared to 472 crores for the PHCs, but incremental costs are much less. Now, interpreting this is very interesting. Looking at the health expenditure in Gujarat over the last few years, you see that the health expenditure has been consistently increasing in the budget of the Department of Health. Of this, total expenditure is about 8% on HWC of the Department of Health. But if you look at the incremental cost of HWC in Gujarat, that comes to about 1%. So it's actually rather modest increase. So what do we actually conclude from this? Now, the conclusion is that, of course, the HWC initiative seems to be modest so far, unlike the PMJ. The costs mean that the government does not have to put in too much of additional resources. However, one very, very important caveat here is that the HWC expansion has not been fully implemented. In fact, not even half fully implemented. So we have only carried out a few of the additional modules. We have not really gone down to the entire list that I was showing you in the beginning. Had we done that, had the government done that, I think the cost numbers would start looking very different. And I think the reason why we did this project at all and this work is that it set a kind of a benchmark for further studies. And it was also a typical example of how costing should be done, how we should be keeping costs right from the beginning. And then now if you are going to expand and add modules of ENT and dental and all of that, how would those incremental costs look like and who would bear those costs? So while the exercise, I want to finish here by saying that the idea of this is not just an academic study. It was an academic study. We've got it published. All that is nice. First of all, what was very interesting about it is that we could go down to the fields. We could actually, the team here, the lady who is doing your MC is actually a very competent researcher, Kanksha. She never introduced herself. Avantika Ranjan is right there. Tushar has been working with us, Mayur and his team. It was a really nice collaborative effort, the way I think your organization is thinking about future collaboration. So the first thing was capacity building, because I think some of my researchers and other researchers actually learned what it is to go to fields, collect data from government. It's like extracting a tooth, actually. So, but that happened. They could do that. They just plonked themselves in the districts and collected the data, helped with IIPH Gandhinagar, certainly. So that was also a big point of the collaboration, that the capacity building did happen. It's always good to push youngsters to do this and get them to publish papers. We are supposed to be mentors. I shouldn't even be here talking about it. It should have been one of the youngsters who should have presented it. But I think initially the whole idea of this IHC was that we should handhold and take the next layer of people forward so that they can now do their research competently and on their own, so that we can step back a little. So that was the second point, and I do hope that in the coming months and years, we see many more such collaborations happen. if you want to ask any questions about the paper per se or the findings, I'm happy to answer those right now. Thank you.
Questions, please, from the audience. One or two comments, clarifications. Yes, please announce your name and where you're coming from.
You can just speak. I can hear you. Oh, acha.
Yeah, thanks. Good afternoon, ma'am. Thank you for that presentation. This is a very interesting study and lots to learn from the paper as well. So thank you for that. I just wanted
Your name and institution that will
Sorry.
help.
My name is Kea Furtado from the Goa Institute of Management.
Thank you.
So, ma'am, I just wanted to, one of the things I think wasn't presented but is in the paper is the proportionate costs of the different components that you looked at. The HR and all those different.
It's there in the paper, but
Yes.
I didn't present it because we got
There's
10
a lot,
minutes.
I know,
Yeah,
no.
it's there.
I just wanted
yeah.
to, given that you've been doing this for so long and looking at costs of various health system interventions, I wanted to know your views on the fact that the HR component is still the major component, right? And even in terms of change, that hasn't changed proportionately as much. Often we hear that there are criticisms of this, but really, does that matter? What do you think from a policy perspective the implications of this are for setting up HWCs? Does it matter? Is it okay that it's still the biggest cost head and it doesn't change proportionately and the spending on the other inputs still remains what it's been at?
So that's a very interesting question. Often you will find people saying, oh, the HR is so high, so that means that nothing else can happen. That's a standard argument, and you're right that HR has to be there. I mean, it's a labor-intensive thing. But the point is, if you break down the HR by subcomponents of HR, that is where, I mean, suppose it's very admin heavy. So it's not, you can't summarily answer that question. I mean, we can do it for HWC, but I'm generally making a point that within HR, suppose HR is 70 or 80%, which is generally the case on many programs. How the functionality of the sub-items is very, very important. So suppose you have a program which is a health program with lots of doctors, you have added cardiologists, that makes a lot of sense. But if you haven't done that, and you are just saying that a lot of bureaucratic, clerical stuff going on, admin is very heavy, that's where your HR costs are going, then there must be some inefficiencies that are happening within the system. Right. And the other way you can do it is compare across states. So suppose you take the same HWC initiative, you would look at Gujarat and you look at another state, and you find that in one state, the HR component is relatively lower, and the outcomes are the same, of course, which is very important to control for the outcomes. Then you know that there are efficiency gains to be made in your HR management as well and your payment. But government programs are generally HR heavy. Yeah. And there are lots of perks and nonsense. So you're not always running on a consultant basis. You do have permanent staff and you do have ad hoc staff. All of that is happening. So I think the point is well taken that you have to unpack the whole HR story to make any sensible comments about whether that's efficient or inefficient. Without doing that, you can't make a summary judgment that it's really inefficient to have HR of 70%.
Absolutely. Thank you, ma'am. That's very useful. And just, may I, sir?
We have 15 minutes at the end.
I can do this
We'll
later.
come back.
Absolutely.
Burning question we can take, but otherwise.
One more question. We will then go to the next question.
I'm Dr. Sandhya Barge from Center for Operations Research and Training, CORT, Baroda. So, based in Gujarat, I think we were also part of the IHSC fundings, the studies in conducting the HWCs. Because you mentioned about the HR and in continuity to what the speaker has mentioned, just wanted to get your view on the performance-based incentives, because as you said that the HR does contribute a major component of the cost, and at the sub-centers level because the CHOs are in positions. But we do have a performance-based incentives for the CHOs as well as the ASHAs. So how much do you think that would really influence the cost of it, or it will not have? So would we say that it will be more of a social motivation for them rather than just as a cost for the decision makers, you know?
So thank you for that question. As an economist, I would say that anything that is performance-based and rewarded is an improvement over the previous system, frankly. So one wishes that there were more performance-based salaries and wages generally. If you are measuring the performance well, and it is not again a routine number, 20 kia, 30, that then becomes an earlier system and it's just a numbers game. But if you're really able to measure quality performance and reward this, appropriately, I think it's an improvement over the system, even if that increases your total cost a bit, because you are actually improving efficiency. So the quick answer is that if it is working well and you're able to measure the outcome, which we are not often doing, unfortunately, then it's a good system. But without measuring the outcome, just saying that you will get X amount of money if you see 3 more patients or whatever, that won't work unless you analyze it better.
Okay, we'll move on to the next presentation by Dr. Dorothy, but I'm sure I do have a few questions as well as many of you have some questions, but hopefully we'll have at the end some time for more questions to Indrani.
Thank you. So I'm Dorothy, and I'll be presenting this paper on primary care models. I'm very grateful for the opportunity to be sharing the stage with mentors and senior people, as well as to be sharing the findings of this study, which we enjoyed conducting because it gave us an opportunity to speak to, again, stalwarts in primary health care. So that, and also I would like to mention how the collaborative experience was also great for us. This study was done in collaboration with ISB, and it was a very nice experience because they brought a different perspective to the table, and we were truly able to share and learn from their experience. So I'll try to stick to time. I may rush through a few slides, but bear with me. So what I'm going to do is basically talk through the results. The background, give you a brief background of why we asked this question, what is the question we asked. I'll talk you through the methods that we did. I'll share some of the results, and then some takeaways for primary healthcare in India. So I'm sorry, I'm moving backwards, aren't I? Right, so without really getting into this, of course, the reason I mention this is also to state our understanding and the framework that we used to look at PHC or primary healthcare, and it's what was envisioned at Alma Ata, what was again recommitted to at Astana in 2018, and we're talking about this as a whole of society, whole of government kind of approach to health with its 3 core components of integrated health services, multi-sectoral policy action, as well as empowered people and communities at the center of it. So this was the idea and thinking with which we went into this inquiry of PHC models in India. Of course, I won't spend time on this. There's enough evidence to say that good PHC systems actually contribute to achieving universal health coverage as well as the SDGs. In the Indian context, of course, also there is a recent push towards comprehensive primary healthcare, and I think the framing of comprehensive is in opposition to the selective PHC, which was predominant soon after Alma Ata. It was interpreted in various different ways and again implemented in different ways, selective PHC being one of them, and therefore this framing of comprehensive to move away from that selective idea of a select package of services. The Ayushman Bharat, of course, has moved this agenda forward by trying to do CPHC at the health and wellness centers. But of course, India has a huge history of primary health care, and Alma Ata itself was born out of examples from India itself. So therefore, the question that we asked was, what is it that we can learn from existing models that deliver primary health care? And when I say primary health care, it's the Alma Ata vision of primary health care. In terms of the models that have been used in service delivery, how have they been financed, and what are some of the challenges that they have kind of reported or faced? So the objective of the study was to basically identify successful non-governmental PHCs, and there are examples within the government where this has kind of been moved forward and also been achieved, but we chose to look at those non-governmental PHC delivery examples and identified from them models of service delivery, what were some of the commonly experienced challenges, their facilitators and barriers. So what we did was first did a desk review, we did a scoping review and identified 72 different examples within the country that deliver primary health care. Then we used the case study approach and selected only 12 cases. There were many more, of course, eligible, but then we had to choose a certain number, so we chose about 12, which was doable, to do in-depth study into. The original methodology that we had submitted included observations and going to these sites and also interacting with the communities that they serve. However, the ongoing pandemic did not allow us to do this, so it was largely restricted to in-depth interviews that were conducted. And we also asked them to kind of share with us their reports, so their secondary data collection mechanisms and the data that they had. We did thematic analysis on the qualitative interviews and then, of course, triangulated all the data. So the desk review, we looked at several different databases, and because it was a scoping review, we went beyond the usual databases. We also looked at YouTube and Google Scholar and other places where generally you would find these kind of examples. We also did a short survey, and we did some informal conversations with experts, and then found the 72 organizations. We characterized them by their location, governance, etc., and identified the main models for service delivery. So what we found is actually, if you look at all the various different examples, there are mainly two ways in which they are kind of organized in our country. One is the typical hub and spoke, the hospital or the clinic with an outreach arm. And the second is a social franchising kind of model, or the chain of clinics. So most of these 72 organizations that we studied could be fitted into either of these two categories. Of course, this is broad bucketing it, and there are, of course, very nuanced ways in which people have done this or operate their hub and spoke model, but essentially it fits into these two kinds of models in the way in which primary healthcare is delivered. If I can tell you a little bit more about that, I know that slide is very busy. You can perhaps see it in the paper. But what we've done is to look at what is the governance model, what kind of financing mechanism exists, and we see that there is a sort of a difference in the way the hub and spoke is arranged and the way that social franchising is arranged. In terms of context, largely the hub and spoke works in the rural kind of setting, much more, although we also found an example in the urban setting. And the social franchising model, of course, works much more in the, has, I think, evolved for the urban context. From these 72 organizations, we then used this inclusion and exclusion criteria to look at certain 12 cases, like I told you. Just to mention the names, some of these may be familiar to you. So we looked at the Ross Services, Basic Health Services, Jan Swasthya Sahyog, Swasthi Care, LCCU, Rishi Valley, and the others. And lastly, the last two are actually collaboratives of primary healthcare, which we also included because these were interesting examples of how several different primary care organizations have kind of come together in a collaborative. So some of the major themes that kind of emerged on speaking to people is we asked about the services. And when we asked about services, they all responded saying that there is no one service package. None of them had an identified service package. In fact, many of them said it has evolved over time to respond to the people's needs. Many of them told us that they started with a situational analysis to look at what are the problems and how they should be responding to the need in the community. So that's the idea of service package that most of these examples had. A lot of effort had gone into community engagement. There are some very nice examples, and I think it's there in the paper also, on how people have used different ways to engage with the community, largely through meetings, community leader meetings, etc., and have gone through exercises of trust building with them. They've all have had to kind of address social determinants also, involve themselves in livelihood issues, social issues, etc. One of the major themes that kind of emerged was about the failure of our current training of medical health professionals across different cadres, not just doctors, and the need for multi-skilled generalists. Also, some of the other themes that kind of emerged were about values and how that's very important and critical, as most people said, to good functioning PHC. The challenges, of course, remain financial. Most of them say that it is not self-sustaining. As I showed you in the earlier model, especially the rural hub and spoke model, 75% of it comes actually from grants and donations. only 25% is what they're able to raise from user fees. Unlike in the social franchising model, where a larger percentage comes from user fees, but however, they do struggle to kind of sustain this over periods of time. A lot depends on the individual and the motivation of the person who is driving it. There are challenges with the local contextual social issues, market forces in terms of diagnostic labs running independently and having to deal with that, as well as with referral. So referral kind of stood out as a major kind of a challenge that was common to most primary healthcare setups. That is something that they have not been able to actually address or come up with, and they all use informal networks largely for referral. I'll skip this one and go on to the takeaways. To be able to summarize the takeaways, I thought this was a nice framework. Again, given it's an operational framework given by the WHO, which identifies strategic levers and operational levers. So if I were to think of some of these learnings and findings, I tried to situate them in this framework and see what is it that we can finally take away. So strategic levers, they identify 4: political commitment, governance, funding, and community engagement. Of which, yes, political commitment is there. There is a push towards primary health care. However, I think that we do need governance and policy frameworks around, especially the training of people and equipping them for primary health care, with an emphasis on value-based primary health care. Of course, there's a need for increased commitment to PHC, and I think this follows well on from what Indrani ma'am was already talking about. These are initial days, perhaps, but we will require much more funding to sustain something like this. Much more effort, of course, into community engagement, into trust building, and to involving the community. In terms of the model of care itself, I'm sorry, slide's not visible, but in terms of model of care, they all had a defined population, so that's one takeaway I take away. There needs to be an area that we are kind of responsible for. It will be context specific, so there can be some things that are generic, but it will always have to respond to the needs of the community, and we will have to address social determinants as well. Workforce training, etc., are some of the inputs that need attention. Engagement with the private sector. So yes, these are not, all of these were not-for-profit examples, and these are examples where it has worked well and that they have experience with. So much greater engagement with them. Purchasing and payments, interestingly, we found no examples directly. None of these organizations had actually partnered or had were in a arrangement with the government where they had been purchased from. Most had been in a reimbursement kind of a model. However, all of them expressed certain amount of wariness with getting into these kind of purchasing contracts because of their own experience with delays in reimbursements and how work then kind of suffers. Digital technologies is again one operational lever mentioned by the WHO, and we found in our study that although yes, it makes things much easier and it perhaps helps to move this along, it's not critical in the sense that most of these places don't really have or leverage digital technologies to the extent that they can, but yet they are able to deliver primary health care. Quality of care, most of them fell back on protocols, putting in those kind of rigorous assessments, quality assurance mechanisms to ensure that the quality of care was kind of maintained. In terms of research, the learning system collaboratives we found very interesting. These were 2 examples that we had in this study, which kind of brought PHCs, people delivering PHC together for learning. So I will end with that. This is my last slide. If we were to take away from this study, that community engagement is both perhaps a strategic as well as an operational lever in our context. It's extremely important and needs much attention. In terms of the workforce, we do need governance and policy frameworks around this to make people much more fit to be able to practice and to contribute to primary health care. The learning system, the collaboratives, like I mentioned, were excellent examples of how learning systems can be inbuilt into the PHC system. An increased commitment for financing, because what we've seen from their example is that it cannot sustain itself. It will need additional inputs. And the fact that values was extremely important and stood out as a major theme. The value-based service delivery, going beyond service delivery to engaging with social determinants, to engaging with people, the kind of experience that Sir was sharing, where you know who these people are. If you were to go back, you would be able to know them. So essentially that's, I think, the end of our paper. We ask for a call to move from delivery of primary care services to actual primary health care. Thank you.
Thank you, Dr. Dorothy. I am told that there are many questions also from the online participants. So I personally feel that we will have the next presentation, next 10 minutes, and have questions invited together, both of the last two presentations and also the first presentation, and beyond that. Thank you.
Good morning, everyone, and thank you very much for this opportunity. And we will be talking about the work that we did in Karnataka on the assessment of current burden of service delivery on ASHAs and the potential role of multi-purpose health worker in task sharing. So moving ahead, I'm really grateful and thankful for the support and at different stages of the study from IHSC, and the kind of partnership mode that we went ahead in discussing various aspects, the research methodology itself, and how we are going to do further. So I have a long list, but I will definitely look at how to do that within 10 minutes. And so in terms of the first, my project team members, I'm was an advisor, but I'm happy to be here, and on behalf of my team, and also I went to the field because it's always very good learning to be in the field. So I continue to do that whatever little time that I could do. So the background, of course, is not anything difficult or not known to people. So we did a scoping research. Then obviously it has talked about ASHA program, the knowledge, skills, and challenges faced. And in terms of the evidence to be assessed for the ASHA workers is where we think we needed to do, and looking at the burden. Everybody has been talking about it. There has been information which has come, and how to really go ahead and use their optimum services, and the potential role if we want to really shift the tasks, or maybe share the tasks that she has, because a lot of studies have shown that she is burdened. She started off as a volunteer. She was primarily for the maternal and child health, but there has been a lot of add-ons. The list from the Delhi is like it has about 56. Karnataka uses about 35 tasks. So these were some of the questions that we had, and the current burden of the service provision, and assess the impact of the role and their quality of life, how it is impacting them, and to suggest the potential role for task shifting, for revival and strengthening. And with our scoping research, and once the study results came, we came back and really looked at. So we have, if time permits, for ideas for policy, we could take it forward and put it across. Of course, the research questions is, their time for, different types of services, documentation, reporting, training, travel, and so on, and the factors that inhibit, what facilitates them, what they feel very good about, what is their intensity of their, emotional part that they invest in, and their physical, psychological, social relationships, and the environment in which they work. And the ASHA's perception related to risk and work balance came up also. So the potential role for the final, we were looking at, can we really shift tasks? Can we really, share some of those tasks? So from the understanding of the concept to data gathering to, we went through all the, from proposals stage to inception to really we worked along with our teams, our partner also, and with the government. And so we also had hit the floor because it was at the pandemic time, and the second wave had affected, and then we had to really get permissions to really move ahead with the study. And Karnataka government, the health department was very, kind of accommodative, even though there were a lot of, questions and time delays. We were able to go to the field, into August of 2021. So the methodology was a 6-month. Due to COVID, the project did get extended. So we worked with the IHSE team on, extension and so on, a cross-sectional study. Then we used mixed methodology and data triangulation. We, had hoped to get a lot of MIS reports and documents and survey data with the government, but they were not very available. We kind of exchanged. We went ahead and spoke to them at various stages. So the study area we selected initially with, based on the increased proportion, like we looked at ASHA proportion to population and one district with medium, large and least. Accordingly, we selected Koppal, Mysore and Ramnagara districts, but the technical committee in the government said Raichur was an important one, being an aspirational district, so they suggested that we change it, and so we kind of went ahead to accept that recommendation. So we used a multi-stage sampling framework, moving ahead from, randomly selecting a taluk, an urban town were selected from each, and then a total of 3 blocks. So we tried to kind of give a good, representation from the districts that we were doing. Selection of the PHCs was the next stage, and the sample population, the way said in terms of the, 2 selected out of the 3 PHC to collect the data. So the sample size covered and primarily on the types of methods. In the qualitative methods, we were able to conduct FGDs. This was with, from 3 to 5 members, because it was also, we couldn't really have larger groups. It was COVID time, so we, went ahead with a smaller number of people in an FGD. So then we did, in-depth with ASHAs, ANMs and multipurpose health workers, key informant interviews, held at the block and district and state levels. We included different people from the health system also. Then we also carried out participant observation, where a person was allocated and 6 participant observations were done for 6 days each. So this was to follow up as to what actually ASHA does on a day-to-day basis. Again, we kind of triangulated that with the task diary, where for the 15 days, a very specific task diary was kept, and we analyzed those data. And then we applied WHO QoLBREF for understanding, ASHA's quality of life and how it corroborates and kind of understand what the final results would be for us to match with it. We, based on the findings, we looked at different aspects of work analysis, performance effectiveness, perspectives, and the challenges faced. So in the workload analysis, what we kind of looked at is the population covered. As we see the results, 60% of the ASHAs do serve more population. So usually it is about 1,000. But generally, we found that they are doing. Of course, the maximum 5,000 is more of an outlier, but we kind of removed that, and we saw, and increased population coverage also resulted in increasing, working hours and also their efforts. Time spent on the routine tasks, we found that 82% of them work more than 30 hours. Like if we go by the ASHA guidelines, it is 2 to 3 hours, 4 to 5 days a week. Definitely, this has been proven again and over again in the studies, and that is proven here too. Interestingly, of course, none of them said they work less hours, and we kind of try to calculate the average time spent on documentation. That was about 10 hours. And what we found is majority of them would say that they would do this documentation back at home, take a lot of evening hours and do that. Accompanying pregnant women for delivery, even though the state, now it is not expected, they continue to do it because the community or the young women also kind of are used to, and they would like this to happen, and so that also takes away on an average maybe 3 pregnant women for delivery in a month, and then about 7 hours because, including travel, sometimes the delivery is delayed. So these are, some of the things that we saw were, in terms of the workload analysis, which means, yes, they are, than the initial contract or the volunteer basis. The tasks, they perform effectively. So, we kind of took ASHA's perspective. We also kind of gathered a lot of that from the KIIs we did. So we, obvious, maternal and child health is where they are able to really perform very well. There are some surveys, they do say that they have been doing, performing very well, and iodine program. And so, how does this really work? Obviously, knowledge and experience. We also took people with 3-year plus, inclusive criteria was 3-year plus, because they would have known and worked in the system. And their interest and liking, because because of their lived experiences, in maternal and child health and others, they really like what they do, and they kind of feel they have learned a lot of knowledge. They are ready to do. They are able to do it, and there's a lot of training that happens, and so they do appreciate the training that goes on, and support from the community, because communities now depend on them for these services. And many of that probably. Because now they're used to, they think it's like simple, easy to do, and they do have other challenges which we will talk about. Key informants again also said RM and CH tasks are well done by them, and they believe that ASHAs received better training, and similar to what ASHAs themselves were saying. And and also some of them said that because they're better incentivized, probably that's also one of the motivating factors, that they are able to perform, they're interested to do it. Perception of the work burden, we kind of again looked at through these interviews, a number of FGDs. We came up that on and on, again, what it came is the survey was one of the things that they found difficult. They found it very burdensome. ASHAs and Anganwadis are supposed to do it together to carry out household surveys on various aspects, ANCs and PNCs included. However, it is highlighted that many of the Anganwadi workers do not share the responsibility, and they feel we're doing it alone, it's been tough, so many more other activities that we do. Data entry into ASHA Soft, again, is not their responsibility, but many times they feel that, ANMs are responsible, but, some of the ASHAs reported that we have to do it, and they also find it difficult because they're not very well trained, nor do they have the skills sometimes. So through this one, we also found a lot of times they, when they have to do certain on the apps, they don't have the smartphones. So they had a lot of these challenges with, digital aspects, and particularly this ASHA Soft. Collection of sputum, I mean, interesting results came up. They don't have to collect a whole lot, but then the transportation is somebody else's responsibility, but majority of the time they feel that we only have to take. So there is some kind of a discrepancy we see when we look at how it is done, and they felt, this was not very easily seen by them. They said it's also very difficult when we go to the houses, when we have to collect the sputum from men especially, we find it very difficult. Frequent and long hours of meeting, of course, this was also the time when we were there in the field. It was, second wave had happened in COVID, so that was another frequent and long hours of meeting was another, very challenging for them. That also included travel to those meetings. Key stakeholders' perspective, they had mixed opinion about ASHA's workload. Many ASHA facilitators and mentors believe that the increased population to cover, increased number of tasks, surveys, and maintaining reports are overburdening ASHA. So they kind of see closely. They themselves were ASHAs before, so maybe facilitators and mentors would be really looking at that. Medical officers also agreed that additional tasks, new schemes, and programs are burdening, and consequently maybe lower the overall quality of work. However, ANMs and the multipurpose people, they felt that ASHAs are not overburdened. At the same time, they acknowledge that they do face difficulties in carrying out certain tasks. Contradictory to this, the state ASHA team lead is of the opinion that ASHAs are not overburdened. However, he acknowledges the efforts of ASHAs, and he says that, because they are incentivized for all the tasks they perform, and he feels that it is not, so bad. Challenges, yes?
Maybe a minute. Can you close in a minute?
Yeah. Okay. So challenges faced, lack of cooperation, survey, and various other aspects. Quality of life, the lowest that they got is environmental part. And the case for, so what I will do is I will use this slide. So what we did was, kind of look at what are the things that the work burden and the challenges at the personal level, as talked about. Limited resources, most do not have own a smartphone. Commute became very importantly this one, and also out of pocket expenditure for transport and other sundries related to work. Excess time and effort, lack of digital skills, stress, less time for family and self, low quality of life due to work related issues. So then the situational was in terms of increasing expectation on different programs, delayed payments, limited community support for certain surveys, and limited support from community on programs other than RMNCH, and limited support from healthcare personnel. So workload and extended hours continue to be a major challenge, which I've already talked about. So in terms of task sharing, what we found feasible is ASHAs want to share the E-Samiksha, ANC, PNC, HBNC tasks with Anganwadi workers, and ACF and LAVA survey to be supported by the multipurpose health workers. And the shifting, maybe all app-based surveys, could be looked at for shifting. Tasks related to providing services for men, especially dealing with men, family planning, NCD, and leprosy, may be really looked at further. So in terms of the recommendations, we looked at reducing the work burden, maybe structure, also like specific work days and work schedule, and also creating avenues for growth, because there are a lot of these people who have worked for very long. They're also very knowledgeable and able to do it. So pathway for career development, because they were feeling very burdened with only doing one thing, but there were some who were good with ASHA soft or technology and things like that. So improve ASHA training on a periodic basis, which continue to happen. Compensation and monetary benefits, especially for travel related, and provisioning of resources for improving effectiveness. In terms of they were unable to get loans, they wanted a long-term security. The amount is very less, because we had about 7% of them in the 45 to 60 year bracket. So they were looking at a few more, part of compensation and long-term benefits. So with this, maybe I will stop at this, because we can take this for discussion.
Yes. Yeah. Thank you very much, Dr. Usha. And before we, select questions, I suppose have been some of them have been selected from the online. I also want to just take 30 seconds that it is impossible, we all know, that to present the whole study in 10 minutes. I would therefore urge those who are present here as well as online to read the full paper from the journal and write to the authors more directly and have them clarified or take it further. So with this remark, may I request Tushar to... Okay, so some questions will be flagged, and I request you to be, Avantika, to kindly help us on this. Just read the name and...
So one question is from Suhas Kolekar. He asks, will you suggest that in view of the climate crisis and resultant heat wave with temperatures as high as 45 degrees for the unorganized sector workers, working hours beg to be staggered and possibly reduced to save lives in a way of the workers and their children from heat stroke?
Anyone would like to generally address or so broad, and I think, would you like to say something?
Yeah. Right. I mean, we could look at. I mean, even during surveys, others also we end up doing that. I think in terms of the morning hours where it is possible that they are doing it, and there is no standard time that you can give for the community part. So maybe supporting, especially for Ashas or other people. For a PHC and others, I think healthcare, as we know, is 24/7. But in PHC, maybe it is certain specific hours. I think that staggering is naturally done to a certain extent, but from a policy perspective, it is very difficult because certain areas like in South, we are not having too much of heat, but North Karnataka has. So yes, maybe we could kind of work that to benefit the local conditions. So, it's not only heat, but it could also be cold in other places. So, yes.
So maybe general policy support for this idea, but implementation at the block level. Okay, we can work on that. Next question, Avantika.
So we actually have a couple of questions from Preetam Mahajan. So I'll read out all of his.
One question from. Because let's try to be a little bit.
So maybe I'll take two questions from him. Firstly, he asks, how are we factoring salutogenesis in HWC? And the other question is, what are the possible reasons why systems thinking approach to deal with complex adaptive health systems still hasn't gained root in our approach?
No, I don't think we are including cellulogenesis. As far as I know, we are not. But Mayur?
I would request the audience to ask question in two ways. One, specific to these questions. Secondly, more on the primary care. What kind of research we can do, challenges and so on.
There's a specific question for Dr. Dorothy. What are some of the challenges in delivering preventive services that are targeted towards persons at the level of PHC or SC?
I don't know if I'm equipped from the study to answer that question, because we did not really get into the different kinds of services in terms of preventive, curative and rehabilitative, etc. But of course there are several general challenges, and I'd encourage the person to look at the paper. We've kind of summarized those challenges in terms of there are financial difficulties, there are personal individual challenges. Many of them shared how difficult it is in many of these situations, which are very high deprivation situations, to deal with the emotional issue of dealing with primary care. So there are several challenges that they mentioned, which we've kind of summarized in a nice diagram in the paper. So maybe they could have a look at that.
I would also request the person to read Dorothy's thesis as well. She discusses a lot on systems thinking. So maybe you can make it open access. Next question, please.
Anuradha Katyal asks, in terms of the strategic levers, do we have any political commitment to engage private providers, GPs, in primary care apart from the PPPs? Ayushman Bharat is a lever to improve utilization of the public sector.
Ayushman Bharat has two arms, right? It has HWC and PMJ certainly has a lot of private providers on board. So we can't make a blanket statement that Ayushman Bharat is only public sector. I mean, that's my...
and also there is some discussion going on in towards bringing primary health care under the insurance PMJ as well. There's not much concrete steps forward, but there's a lot of discussion going on. Next question, please.
Harsh is asking a question, isn't using them as activists giving a high workload for a low pay, in a way a large-scale exploitation of the vulnerable? I think Professor Usha is...
in terms of... okay. Definitely, the demand, as we know, from the unions and various aspects, regularization. The pay varies from 4,000 to 10,000 across the different states. In Karnataka, it is 5,000. and I think Andhra Pradesh gives about 10,000. So there has been a lot of this in terms of the incentives and the number of hour work in terms of maybe regularizing, but that's a major strategic shift and the policy change, that has to happen. But in terms of the, how do you really do that? But within the framework of, instead of the activists or the volunteers, definitely yes. I mean, Asha word itself has been a very great one. They've contributed very well. Maybe to look at further policy would be to see how they can create a cadre within themselves, and maybe see based on the skills, training them and or even giving them, additional this one for them to go for doing BSc nursing, those who are eligible and so on. Those could be areas, I think, which could be explored. In terms of, yes, at this stage, there are a lot of, discussions going on, how to really look at that.
Can we take a couple of questions from those who are present here? Any remarks, questions, comments, clarification from the audience here? Anyone? There is one person there,
yeah. Thank you for the good deliberation. I really enjoyed that. Shyama here from Samantran. So we also were part of the IHSC group for one of the studies. So I just have a question both for Dr. Dorothy and Professor Indrani. This is, both of you have talked about costing and understood the challenges at a PHC level. And it emerges that ensuring primary health care as such in the current situation looks unsustainable unless and until there is a provision of support at the state level or a national level. So we are actually looking at a very strong implication here in terms of understanding, therefore, that what could be the role of government in private care, and if there are multiple models which are existing, so how do you then sustain? Do we create an essential health package there and say that yes, this is what is the way forward? Or I'm sure there would be more studies to talk about this. How do you think that the direction that one could take, given your experience, ma'am?
So thank you for that question. It will be a longish kind of an answer, because the question has another hidden question in it. Do I think that the HWC initiative is a good one? Coming from a health financing perspective and a person who believes in UHC, I always thought that a comprehensive package, a benefit package, meant that you're covering primary, secondary, and tertiary together. Now, HWC is a slice out of that, and PMJ is another slice out of that. So as an economist, it's inefficient to do this kind of pooling. It is not really pooling. So what we did was we just costed the HWC without making any value judgments. As strengthening primary care is always a good thing. So between the two initiatives, HWC is definitely the superior one. Is it sustainable? Do you need private funding? If you look at the budget allocations in the last 2-3 budgets, you don't see any enhancement in allocations for either PMJ or not much for HWC either. So one is left wondering how actually you're going to sustain this. Because if you're going to be involving private providers in your primary care, I think that remains a no-no at this point. It isn't a good idea. But the moment you are not pooled, you have left PMJ and you've left your primary care separately, there are distortions that you've already introduced into the market. So I didn't want to get there because I have very strong views about it. But yes, it is a real issue if budget allocations are not forthcoming. Now the Gujarat model of HWC showed that it's a modest increase, and Gujarat is able to possibly bear it, even without the centers, funds and all. But all states cannot. The EAG states cannot. So sooner or later, if you're really going to give primary comprehensive care with a long list of 12 items, you're not going to be able to sustain it. No way. And we really have to look at allocations. Allocations have not gone up for the health sector in the last 2 budgets. Despite all of those fancy calculations of 137, it hasn't worked if you unpack it. So yes, it is going to be an issue.
I I'll take only.
Can we, if you don't mind, request that gentleman there, and I'll come back to you. Yes, please.
Sir, I hail from Kashmir, and I share experience. You have a very right topic today. Research is a later on. I wish that the focus should be only on primary care so that the basic things are met. I share with you because I am based in Pahalgam. That is a base camp of Shri Amarnath Ji Shrine board. From there, 5 to 10 lakh people every year, they visit Shri Amarnath Ji Shrine. In 2012 and 13, I'm sharing my experience. That's what I wish that there should be focus on primary care. And in 2012 and 2013, the casualty because of the cardiac arrest, because of the high altitude, was more than 2,000. And the Honorable Supreme Court was so much concerned that if it is a situation, there must be something wrong with the system. So primary Honorable Governor, that time Mr. Vora was very serious about it. He called me because I work for an American university as a Pro-Chancellor, International University School of Medicine, Michigan, USA. We are specialized in clinical cardiology, and particularly for the cardiac arrest. Unfortunately, in the doctors, those were used to be posted for en route to from Baltal, and there's a route from Pahalgam to Shri Amarnath Ji. They were just simple MBBS, but very unfortunately, they didn't had the basic. That's what I'm sharing. Primary care for the cardiac arrest. What they will do? There's a cardiac arrest. They will just pack it. They will just pack it and they will send the patient by helicopter to Srinagar. By the time on way, he will die. So my proposal, my suggestion was to the Honorable Governor was that we should strengthen maybe MBBS, but they are not fully aware how to resuscitate and how to revive the patient so that by the time he reaches Srinagar and he is okay and he is fine. Resulting that there were only 150 casualties because of the cardiac arrest in 2014 onwards.
Okay, so you have a question also?
No, this is a suggestion also,
okay.
And this is also very important, relevant to your focus on primary care. So my request is, all the MBBS, all the person, maybe senior level, maybe postgraduate, maybe they should be aware about the primary cure for a patient. It is not necessary that the man is serious, then they will come
yes,
and we will make a research. Thank you very much.
Thank you, sir. Sir, Professor Kotwal.
Just a few comments and some questions, which I think maybe answers could be discussed later on. One is Ayushman Bharat, just for information of all those who are online too. I think it is 4 pillars now. The HWCs, the PMJ, and also the digital mission and the ABHIM, Health Infrastructure Mission. And I think all are now impinging upon the primary health care. And as Professor Muralidharan mentioned, there's a talk about insurance component towards, but I think we should resist that. We should resist that with fully, even from the research findings and all also. Why some of the district hospitals are utilizing PMJ and all for the secondary care right now is for generation of funds and all, and the government has realized that whether the funds go to states through the HWCs or through the PMJ, this is the same kitty which is being utilized. But of course, it has challenges because the person whose overall limit is 5 lakh per annum in PMJ, if that is being utilized for routine secondary care, what happens tomorrow when that family needs something for the tertiary care? But that's something to be debated upon, which from the we could look at it from later on from a research perspective too. I am frankly of the opinion, which is my opinion, not the Government of India's opinion right now, that we should be looking at only the secondary care which is not available in district hospital level and the tertiary care for the PMJ component. The others should be provided from the Government of India, the financing board. Just few 2-3 comments that starting from the last study, that since it was brought out that ASHAs are overburdened, especially, So it gives me a cause of concern that we are thinking of rolling out more packages, and they are being rolled out. So how to involve them effectively, how CBAC form will be filled up and all, and how the screenings will be, we're getting huge numbers, but what is really happening on ground? So I think we need to look at that when you do further study on this. The other was the second one was Dr. Dorothy's. You looked at only private PHCs, isn't it? Not at the government facilities. Yeah. So we need to now discuss that with the relaxed norms even now, which will come up very shortly. And also states are now ensuring that as per the norms which are currently available of 5,000 and 3,000, which you all are aware, to create these facilities. Funding available under 15 Finance Commission and PM ABHIM to create these facilities, which is already there in a time-bound manner over the next 4 to 5 years. Are these private PHC efforts really required? We should look at the model of Delhi, Mohalla clinics. They're providing only curative. There's no preventive promotive. There's no follow-up. It's a good model for curative, but not for primary health care. And to think that Mohalla clinics will get involved into preventive and promotive, it becomes very, very difficult working from a small container. And I'll come to your question also, Professor Dani ma'am, that they're being incentivized for the numbers only. So a certain amount, X amount per patient. How many are really seen, and that too seen only curative part is given. So I think we should now discuss this and probably generate evidence that these private PHCs is not required if the government is providing in that area, in that catchment area. And rather we should be making a case of advocacy to the government that you have to provide in this area the primary health, comprehensive primary health care. And look at further involving how more CHWs can be involved, or Ashas even looking at their norms probably, even though the numbers are more. I think I'll stop at that. We can discuss more later on. Thank you.
Thank you, sir. We'll just take as remarks or questions, not
respond.
No, I would request that we have to restrain some more, and we'll just take your comments and questions from Professor Venkat and.
Yeah, this is only a comment. Just to respond to one of the questions that came from the online, as well as some of the questions that were directed to Professor Indrani. I think there is a lot of concern about the private sector coming into play. All of you who are familiar to the TB program currently in operation should see the disruptive mode in which the private sector is getting engaged in now. We have conventionally thought about private sector only from the point of view of purchasing or maybe contracting, but that's an example about how you can get the private sector to provide an entire continuum of service and charge according to a patient that get cured, rather than looking at the input components continuously. Okay, that's number one. Number two is the second issue. Therefore, my first concern would be to look at the private sector engagement not from a conventional thought, but to look at it in a different way, which is going to generate a lot of research questions. The second thought about is in terms of anyway, I forgot that.
Okay, so one final point from you, sir.
Yeah, thank you.
Yeah.
This might touch all the three studies. Basically, one of our key elements in the fight against COVID was the frontline workers. We all know how important that is. And one of the studies, the ASHA worker studies, also talks about the well-being and what is required, like what are the challenges. What I feel is there is a need for a system to be proactive about well-being and growth of the healthcare providers. It was actually a question, but given the shortage of time, I'll just put it as a comment. Like, what is required for us to be proactive about it? In terms of system, in terms of costing, in terms of governance. But I feel there is a need not just look at what is the healthcare provided to the customer satisfaction, but also the provider satisfaction within the system.
Thank you. I'm really constrained to 30 seconds, sir, if you don't mind.
Yeah.
Yes.
So I will. Yeah. I'm Satya Das from IIM Lucknow. We are also associated with the ISC. We're doing a study with Saha Manthan. So actually, I have gone through Professor Indrani's the study. From that perspective, I am talking. So I am a professor in marketing. Most of the studies I have gone through this healthcare, also this cost calculation, total cost by footfall. So she has also given some remark about the limitations. So this total cost, whatever the investment is done, and footfall, if you will relate, there are several limitations. One is that sometimes it may happen, even if the investment is not happening, still the footfall is increasing because of some emergency situations and everything. Second thing is that even if the cost components, what components actually contributing to footfall, or more than footfall, the experience, what Professor Indrani has told. But we are not getting most of the studies in healthcare investment and real evaluation, where the customer experience and satisfaction, patient experience and satisfaction, very lack of studies. So actually, how much the investment is translated to the experience and satisfaction, more studies should be done, because government is doing a lot of investment in different sectors. We have seen in COVID also, vaccination programs. If you go to rural areas, so many people are dragged for vaccination and people are not doing. So many money is actually spent for awareness and
Patient
knowledge.
satisfaction as an aspect of quality is certainly is in the agenda.
Yeah.
Maybe her study is not capturing that immediately.
Programmatic cost of scaling up.
So, but that's a under-researched area.
So that I am telling. I am not telling. I am not criticizing what she has done.
No. Thanks for the flagging it.
So I am just telling this is a future. We should do more research in this area.
Yes.
That is the thing. Condensed.
Thank you very much. I'm extremely thankful to the three presenters and everyone who are present here, and those who are online for being part of this event. Let me not try to summarize anymore, because I am the reason for restraining everyone to conclude. May I now request Kansha to make the concluding remarks.
Yes. In case there are any more questions, please feel free to email them to the authors or to IHSC, and we will facilitate having them answered. Thank you, Professor Muralidharan, and all the panelists for your presentations and for this stimulating discussion. May I now invite you all to take your seats in the audience.